Well, good morning, everybody. My name is Garrett Schmidt. I am the managing editor for BBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by HealthEC, and it is titled Real Social Influencers, How Prince George's Healthcare Alliance is Breaking Down Numerous Barriers and Building Stronger Communities with Social Determinants of Health. So it's a case study, and we're really excited about this. I think you guys are going to really enjoy the discussion today. A few items of note before we get started. This is a traditional webinar format, so everyone is joined in listen-only mode, so you don't need to worry about muting your microphone or anything. That's been done for you. And also during the webinar, we do want to hear from you. So we're going to have a time for Q&A towards the end, but you don't have to wait until then in order to ask your question. So if you have a question at any time, go ahead and use your attendee module. There's actually a space for questions, which is different than the chat. So you just put your question in there, and then we'll get to as many of those as we can during the allotted time. If we don't get to yours, someone will respond to you via email to answer your questions. So please don't hesitate, even if we're wrapping up at the very last minute. Go ahead and ask your question, and we'll get back to you. And then finally, today's webinar is being recorded. So what's going to happen is when we're done, a few hours after the end, I'm going to send out an email to everybody, and it'll have a link to the recording as well as to the slides from today's presentation and some more information there for you as well. So definitely hope that you will rewatch it, share it with colleagues, friends, send it along. We hope that you do that. And then finally, without further ado, I'd like to briefly introduce our speakers today, and they'll give you a little bit more of a drill down on themselves. But we have Ms. Sita Kapoor, who is the Chief Information Officer and co-founder with HealthEC, and also Ms. Barbara Banks-Wiggins, who's the Executive Director of Prince George's Healthcare Alliance. And again, they'll give you a little bit more introduction on themselves. So welcome.
Thank you.
Thank you.
All right, Barbara, did you want to get us started?
Sure. I'll be happy to introduce myself. Barbara Banks-Wiggins, Executive Director of the Prince George's Healthcare Alliance, and I have over 30 years of experience directing award-winning multi-specialty healthcare operations and managing multi-million-dollar budgets. As the founding executive director, I have areas of expertise in population health and care coordination program development, interagency collaboration and community engagement, along with practice transformation and information technology adoption. My organization has developed and created a community health worker program for the Prince George's County. And we have, through our experiences, really seen improvements in how clinical, behavioral, and social determinants of health barriers for high risk and vulnerable individuals really have improved outcomes, reduced hospital visits, and reduced cost. And our organization is recognized for our efforts as a nominee of a 2021 National Health Quality of the Year Award. And also we're recipients of Health Quality Innovator of the Year Awards for Best Population Health Program in the state of Maryland and Best Patient-Centered Program in the state. So we are happy to be here. Thank you for this opportunity. And I hope you find the information that we share to be helpful.
Thank you, Barbara. I'm Sita Kapoor, the CIO and the co-founder of HealthEC. I have been also in the healthcare space for 30 years, so Barbara and I share a lot over here. Have been working in the data area of data aggregation, data science, bringing data from dispersed systems into a single and running business rules on it, all the way from clearinghouses to HIEs to the value-based contracts, or now working very closely with Barbara and team on the SDoH initiatives that are in place. I really am honored to be here and to be able to speak with Barbara at this presentation, and hope you'll find this information useful. Please send us questions all along the way.
So as we know, the National Hunger and Homeless Awareness Week, we wanted to remind you, is this week, which is an annual opportunity for us to bring attention to problems of hunger and homelessness in America. According to the CDC, on any given night, hundreds of thousands of people are homeless in the United States, whether it's chronically homeless, temporary lost shelter, or fleeing domestic violence. And we know health problems among homeless persons results from various social factors, barriers to care, lack of access to adequate food, and then lack of connections to social services. So during this presentation, we'll share how our organization assesses the social needs of vulnerable populations and how we use technology to track and monitor our efforts. Next slide. So Prince George's Healthcare Alliance, Prince George's County, Maryland borders Washington, D.C., and serves about over 900,000 people, are residents of Prince George's County. And we, the Prince George's Healthcare Alliance, are an award-winning nonprofit organization focused on assisting individuals with decreasing overutilization of health system resources. And the way we do that is to train and deploy community health workers who provide care coordination and evidence-based interventions that really help people address their clinical, behavioral, and social determinants of health. And social determinants of health, as we know, are the conditions in which people are born, grow, age, where they work, where they live, but they're also factors that impact a person's health outcome. Even though the healthcare industry spends the majority of funding on clinical interventions and clinical services, we know that social determinants of health really average much more than that. Maybe 60% of a person's outcome is determined upon the social barriers that they face. Next slide. So to help combat this challenge, the Prince George's Healthcare Alliance, our vision is to help residents change their health behaviors, achieve their best health, and optimize community health. And we serve high-risk patients who are in poor control of their chronic illnesses, don't have connections to family or social services, have unmet behavioral health needs. Maybe they need help with medication management, don't have a primary care physician, or haven't seen their primary care provider in a long time. Maybe they are uninsured with care gaps. And we know that all of these factors result in hospital readmissions, multiple inpatient visits, multiple ED visits, and 911 calls for non-emergent reasons. Next slide.
And Barbara, thank you. We've been working very closely with Barbara and her team at Prince George's to get the HealthEC population health tool. We've been working closely since 2018. They have been actually pioneers in helping us design this system and to ensure that they get the assessments, the workflows, which are truly needed for them to be able to manage that population. We not only have them use the tool, but we also get information from an HIE to give them those that have been to the hospital or been discharged. So the tool that HealthEC has built with the assessments and the patient documentation, and also as you go through assessments or as you go through the care pathway in the community for the patient, you're looking at their problems, what are the goals, what are the barriers, and automatically creating schedules for a patient at the patient level, which then allows their staff to be able to quickly get to the tasks they need to do and streamlining all of this using the tool. What this has done is help them, and we will see some more data around it, to reduce hospital visits, cut hospital cost, provide care for underserved communities, improve community health outcomes, capture and track the interventions, monitor, and we will show you some of the analytic reports we have, that as you do the work in the tool, we're actually monitoring the productivity and seeing what's working and not working. So we constantly are looking not only on the tech side, but also on the workflows on how to improve taking care into the community and being able to bring not only the clinical, but the social aspects into a single platform, allowing a continuity and a 360 view, not only in the clinical, but a true 360 view of what and where the patient is. The data is further exchanged with the providers and other entities that need to provide the clinical support for them also. HealthEC has been certified best in class 2 years in a running, and we are proud to work with Barbara and her organization to get the certification. Their testimonies always help us, and we will see some more testimonies as we go along.
Thank you. We are thrilled to be able to have this community health platform because it really helps us to serve the needs of our clients. When we first started building a very comprehensive care coordination community health worker program, there were no systems that were available to really help us track and monitor what we do. And we felt it was hindering our ability to report our impact, to identify what trends are existing. And so with the platform, the system helps us determine barriers by identifying social determinants of health and barriers to care that impact clinical outcomes. And so with this, we are able to use the built-in social determinant health assessments that help us to track, monitor, and document an individual's problems, goals, barriers, and then the interventions needed to help them address them. Aggregate patient data is available from multiple sources to provide a comprehensive view of clinical and statistical outcomes. And so this data from siloed sources helps us to create a comprehensive care plan, again, outlining the needs of the patient. This helps us identify barriers in care delivery and resource utilization across multiple programs, helping us to track interventions, timelines, and identify patterns that help us to develop appropriate programs that align with the needs of the individuals that we're serving. There are design tactics to help us overcome implementation barriers. So through the use of the social determinants of health and disease-based assessments, it helps us to allocate resources and identify the greatest needs and provide care gap reporting, care manager tracking, and then intervention scheduler helps our community health workers and care managers to identify the specific tasks that are needed each day to help them achieve their goals and stay on track. This information is also shared with primary care networks, where we're integrating with them and incorporating data that helps us to present a comprehensive overview of what the patient's needs are. And then these care plans help us share and discuss the needs of the individual in our case conferences. And most importantly, we're able to track the community resources that our clients are referred to. This really helps us to advocate for their needs, help them with encouraging self-management principles, and through the referral processes and the referral documentation, our care managements are able to understand some of the most important resources and information to provide to primary care providers and specialists in addressing the social needs and barriers of our clients. Next slide. So the care coordination technology platform gives us an overview of a comprehensive overview of what the multiple needs are of the patients that we serve, including, starting at the left, linking to community resources, helps us track and monitor what community services an individual has already been referred to so that there is a reduction in duplication of efforts. We provide education programs that help patients to understand how to manage their health better and how to optimize their individual health through the education and health literacy programs that we connect them to, as well as the educational information we share, and that is documented in the platform. It also helps us with provider engagement. Sharing these comprehensive care plans really engages the entire care team with understanding the needs of the patient. And we know that combining all of this together really not only improves health behaviors, but also improves an individual's ability to manage their health and communicate with their care team and improve outcomes. Next slide.
Thanks, Barb. So it's extremely important. Yes, can you all hear me? So it's extremely important that, as Barbara mentioned, the entire care management and the SDoH, that HealthEC has been aggregating data. You can get referrals that come directly in, or you can collect data from claims, from HIEs, providers, hospitals, and EMRs, which are aggregating it to create a single longitudinal view in the community health. All this data comes into our data warehouse, and the connectivity and the quality of measures and reporting allow users to monitor, utilize the compliance and the performance. Over the years, working very closely with doctors and nurses, we have built business rules that help create the pathways in the community. We have built the workflows around the business rules that then enable the care coordinators to know what they need to do at a patient level. There are embedded assessments in the system. We have over 200 assessments over the time that we have built. And as the care coordinators take these assessments or assess the person, we are able to then automate not only the risk for the patient, but also the problems, barriers, goals, and interventions, which then continue to flow into the workflow for the care interventions that need to be provided. This is truly a data-driven collaboration between the Medicaid agencies, payers, and providers to facilitate via shared reporting and care plans. It's most important that we just don't capture the data. We actually build a whole follow-up plan for that particular patient at the patient level, not at a disease level or at a procedure level. It's truly trying to find out the details of that patient, including all the social determinants of health, so that we can truly start to drive health equity. As we all know, that has become more and more important in the work that we do today in the healthcare space. We do also connect with other entities like Unitas with single sign-ons or NowPow, which allows us to do referrals interoperably into the community. So it allows for a seamless flow of data between clinicians and social workers to be able to provide that complete care that is truly needed for that patient. Barb?
Thank you. So one of the most important things that the system helps us with is our impact. And I spoke to you about that earlier. We actually used data from the system to create what our impact study, which was a pre and post of an individual's hospital visits or hospital admissions, pre and post intervention or enrollment into our program. So we served over 2,000 patients. However, 163 were enrolled in our intensive care coordination program. These individuals received evidence-based pathways that were documented into HealthEC, which helped us to realize the volume of work that goes into reducing hospital costs and hospital visits. These 163 people received hundreds of phone calls, 258 emails and texts. There were 73 provider conferences held on their behalf, and 723 intervention pathways were created, tracked, monitored, and completed. Of these 163 patients, We did a pre and post. How many hospital visits did they have 6 months prior to being enrolled in our intensive care coordination program compared to 6 months post enrollment? And we found on average an $11,000 decrease in hospital charges per patient, or a reduction of 42% of hospital visits per patient. So it's important to have a system that allows you to document the work that you do, track the interventions, and then report the outcomes so that you can understand the impact and then present that to funders, to and other organizations that need assistance, so that you're validating the impact and the effect of the work. Next slide. So this is a report of our 699 clients who were in our intensive care coordination program. And through our documentation in the HealthEC platform, we were able to identify the productivity of the care coordinators. These 699 high need, vulnerable individuals had over 2,000 social goals met. We were able to track that over 8,000 phone calls were received by this group of individuals. We completed nearly 4,000 interventions, sent a total of 1,300 plus emails, text, letters, conducted 579 home visits, and again, we're able to track and monitor the number of provider conferences that it took to help these 699 people meet their social goals. So again, the system helped with this tracking, monitoring, to really validate the impact of our program on the community.
Thanks, Barb. Am I more audible right now? Some people have said that I'm not as audible. Can you all confirm?
Yes, you sound better, Sita. Good job. There we go.
Thank you. The lawnmowers came right at that time. It's just so very quickly coming to the HealthEC platform. So HealthEC platform was primarily built for ACOs. We started with the pioneer ACOs, and for providers for clinical outcomes and more to drive utilization. Then we started working with Barb and team to enhance this Connect platform for SDoH and for the community workers. This system is bringing in data from multiple data sets, from your claims, your EMRs, labs, PBMs, Unitas assessments, coming in from data that comes directly from HIEs. So we are able to get all of this data and create a very customized dashboard, because this system can be utilized by providers, care coordinators, by your social workers, like Barb's team, has multiple people. And it is, Barb, I'm sure you can attest to this, it's simple to use, it's very easy to configure, and everything is configuration based. So all the widgets, all the KPIs that you would like to run are all based upon your widgets that are enabled in the platform at the time, or over years, we can keep enhancing it with more assessments that need to be added into the system. Now, for the SDoH space, the assessments are the key, because there is no one that's collecting this data today. So organizations like Barb's are extremely important to in our community to start gathering this information electronically, so that we can use it for some actionable insights and provide that at the point of care, whether it's within a clinician's office or it's in the housing department or for a transportation. It's to manage that patient in this community as best we can. So you could go into your food, and for every county or every area, the list of people that you can contact or who you need to are different. There are organizations gathering that information, and we work with them to bring that information dynamically into the system. So it becomes, we try to automate as much as possible so that the person using the system can very simply, go to an assessment, click, you can get a problem barrier golden intervention, or you can create one yourself. You can create a recurring event. This then creates that pathway that you need for the patient, whether it's clinical or SDoH, in the community for someone to follow. It also allows that intervention to go either to a provider in an FQHC or to your social worker, or even to the patient, as a matter of fact, or someone taking care of them, or a nurse. So the system is built to allow this data to flow seamlessly and provide that care that is needed in the community. And like I mentioned before, HealthEC has been best in class in 2019, in 2022. We have multiple, and I'll get to the next slide. We track the patients and capture. So again, bringing back, very important, the data sources coming into your now universal data warehouse, and we can provide care and quality reports where HEAT is certified with NCQA, run the quality rules to create this personal care plan. This has been built by doctors and nurses who have been our partners in bringing this to be seamless. All the work that was done on paper in 2013-14, we worked very closely with them to see how it could be automated, made simple, and create the actionable rules that are needed to create an intervention schedule or outreach and context. So disease-based rule, quality engines all feed into a care coordination, a care prioritization. It's very important. You have 10,000 people to manage. Who are the high-risk patients who have been discharged that you need to get to right away versus those that are on a disease and you can get to them tomorrow. So this helps you re-strategize constantly. Even the assessments that you do have a score which gives you a level 1 through 5 that says, for this particular disease, what is the risk? Allowing you not only to take a risk at a patient level, but at the disease level also, whether it's diabetic, asthma. So we build a lot of NANDA assessments into the system, which can then be rendered on your portal or on an app or embedded. We have worked with some of the EMRs to embed this into the systems also, or work with bi-directional single sign-ons with multiple entities. The goal really is to be interoperable. We are fully FHIR enabled and are very happy to work on integrating this, because where we are in healthcare today is where we are, and how to get further is a collaboration with everybody that we are talking to or who's listening into this conversation. We have to take the strides to make this data interoperable and get it to the point of care where the care is being given to the patient, whether it's at the community provider level or a social agency or a community agency or a caregiver. That is the one single objective that we've been striving towards in HealthEC, with collaboration with Prince George's and our other valued clients, to be able to create a seamless system in the community with one care plan that can create your actionable care pathways at the point of care where the patient is. We can gather data, but if you don't analyze the data, I'm a data scientist, so for data it's like, wow, great. So if we take the data and we keep analyzing it to make sure we can see what is working and what is not working. These systems are new in the community. We need to figure out what works and what doesn't work. And Barbara and her team have done a fabulous job on capturing the data at the unit level so that we can then apply data science to it to look at, how are we doing in different, preventive measures, or how is the COVID, especially during that time the system was used for the assessments that was needed and to reach the patients, and using the context and outreach to see who we can reach and who are unreachable and how do you escalate it. Or if you get an assessment done and you now are high risk, how do you escalate it to a provider right away? Also looking at the productivity, how many patients are assigned to the panel, what is working, what is not working, allows these type of reports that we constantly review, helps us enhance on the tech side, but more importantly, what are the community workflows that work, and then with Barbara and her team, publish it so that everybody can take advantage of it. We are all here to share this information so that every community can get something of this, technology solution which can truly capture information and provide the actionable interventions. Even the assessments we do, we are able to slice and dice them. We can determine, how are the questions being answered, which are the members or the clients, and the multiple terms used for them. Patient, member, subscriber, client are all one and the same in this world. Is the person that we are providing the care to. How are they doing? And we can quickly start to look to see, what was our outreach month over month, year over year? Where are the key problems that we need to start focusing on and build? Either go for grant money, like Barbara and team are doing a great job doing it, or to be able to work seamlessly with the Medicaids, or with the health plans or the states to create programs that truly will help that community. Every community is different. We cannot apply one to all. We all know that. How do we find what is really needed in that community can be driven by the data that we gather and the analytics that you provide on top of it. Health equity dashboards are becoming extremely important. We all hear about this, especially, post the COVID era, as we call it. How is the population doing, whether it be by gender or by age group, or, homeless indicator, race, sexual orientation, are you looking at language? So we have been able to harness this data. Of course, we all understand that we need to gather this data more accurately. That is, lots of states and lots of companies are out there trying to do that. And we also have an HRS tool, a health risk assessment screening tool, which can gather that information right on the platform and then share it with everybody, plus drive it to analytics to start to truly look at how is the patient performing, and what are the demographics that we need to focus on, and what is the health equity data, and how do you geo-map it? This can also lead to, one of the requests that we got very recently was saying, all right, you've got the patient, you know their language, here's the provider directory, and these are the details. Can you tell us what my network advocacy looks like in this area? Do we have enough, if the population is highly, has, heart problems, do we have enough cardiologists who speak that language who can really help? Those are the type of questions that we can really start to harness and look at the data and provide some answers. So collecting data, aggregating data, collecting data, and then applying analytics on it to be able to determine how to improve workflows as well as how to manage that cohort better. Some great testimonials, and this will be shared with everybody. Barb, you can take the few that your team has found. Barb,
Yes,
you're on
I'm
mute.
thrilled about that. Because we were able to provide the outcomes and the reporting data of clients served from some of our provider organizations, we were recognized by them, being able to see and demonstrate that we are experts in community health worker integration and team-based service delivery. How our community health worker interventions and programs have decreased hospital readmissions. The system and the care conferences we participate in help us to build partnerships and relationships with our provider organizations. The HealthEC services helped us to really organize our entire approach to documentation, tracking, monitoring, and improving our practices. And we are happy that we are able to create dashboards and care plans that really help the entire care team understand the challenges of their individual patients, as well as interventions and efforts to help them address those challenges and improve their outcomes.
Yes, and like I mentioned, we are, best in class HealthEC's platform thanks to all our clients and partners, 2 years in a row. And we've got some great testimonials. Some of them are, included over here. Our working, the way everybody that works with us is our partner, because we need to work collaboratively to bring the solution to the next stage, to the next era, as I would put it, for healthcare. So collaboration, listening to what you all need, and working closely to constantly updating modules or to enhancing them or to getting more features into the system has been what we strive to work very closely with everybody. Some challenges and best practices, Barb.
Yeah, I've heard from our provider partners and organizations that addressing social determinants of health is a challenge. It's challenging for many reasons. Some practices and providers are not aware of screening tools to help them identify a person's social barriers. They may be uncomfortable screening because, once again, if you're screening and you identify someone with a social need, what then do you do on top of all the other multiple competing medical support priorities you have for that patient? There may be lack of data on Health and Human Services and community organizations to help with addressing the barriers, and practices may not realize the value. Hopefully some of the information that I shared shows the positive outcomes that can be achieved when addressing social determinants of health. So what we recommend is that provider practices adopt social determinant of health screening tools and identify social determinant of health positive patients that can really help improve their outcomes. If a practice isn't aware of what to do once a social determinant of social barriers identified, then we recommend reaching out to a community-based organization who can help you with lists of services that are available. Find a technology partner that understands social determinants of health and can really help you integrate the screening and assessment process into your daily workflow, and then help identify quality measures that are tied to social determinants of health, and then demonstrate return on investment.
And I think with that, we are on the next slide of question and answers.
Okay, well, thank you guys. This was a wonderful presentation, and we do have a bunch of questions that came in, so we'll get to these in no particular order. By the way, if you do want to submit a question, you can do so on the, you have a module, an attendee module, and you can submit the questions there, and we'll get to as many as we can today. Okay, first question here, and these are in no particular order, of course, is, let's see, it says, excellent presentation and good work. How has the Healthcare Alliance improved measures of health, such as control of high blood pressure and LDL, cholesterol, A1C for diabetes, and more optimal guideline directed medical therapy for heart failure, influenza vaccination, colon cancer screening, etc.? Have you been able to achieve top decile performance?
That's a great question. That's a loaded question too.
That's a lot.
That's a loaded question. That. So as a nonprofit or community-based organization, we partner with hospitals and primary care practices. And what we do is our contribution is the care gap. So in assisting individuals with improving their outcomes, of their, whether it's their improvements in their, A1C or their LDL, we receive a list of patients from a practice who have not been to see the doctor, have not had their labs, tested. They haven't been in to see the doctor. They're not taking their medication. And we do outreach and education to them on the importance of addressing their their medical conditions, teaching them in layman's terms how to manage it. So what we do is connect them to the information, provide them with evidence-based literature that the practice and the provider supports. And then over time, calling and reminding them of appointments, making sure they have transportation to the appointment. So all barriers to their following the patient's care plan, following the doctor's treatment plan is what we do in order to help address their needs. So then the practice does the pre and post that demonstrates a person's improvement.
Very good. I know that was a lot, so I appreciate you going into that.
And it can be for any, whether it's for someone who's diabetic, someone has high cholesterol, or, I did mention, screenings. We'll get a list of patients who haven't had a mammogram in X amount of time, call them up, educate them, get them in, connect them to those screening services so that those care gaps can be addressed.
Great. Next question is information regarding the patient's housing, food insecurity, and other non-medical data collected? And if yes, how is this data collected?
Oh, that's a great question. That is the most important part of what we feel this system does for us. We document the social determinant of health Z codes in our system that helps us track. We're also documenting, that's part of the problems, that's in the particular part of the platform where we are able to document a person's problem. It's more than just, they have diabetes or they have heart disease. We're mostly focused on documenting the fact that they have food insecurities, that they have housing instability, that they have poor social support. So all of the social determinant of health Z codes associated with social factors is what we document. And that's a lot of our focus. And we're able to know at the end of the of a particular month, how many people we served who had food insecurities? How many people did we serve who had lack of transportation through the doctor's office? How many people did we help connect to food service programs? And the goal is to make sure those programs and services start and that the person's social barrier is mitigated.
And all the data is provided right on the system. So even who to call, under what circumstances, whether it's a SNAP or a woman's, or it's all on the platform itself. It's all dynamic tables, and based upon where the system is implemented, we're able to source that data from the entities or directly, or whoever is working on the system can provide that to us. This then allows everything to be in one place instead of them having to, find this document, call this person. And if the system gets more integrated, the goal really is that we can send a referral. Today we do it for a few clients. We can send the referral within that community. Right now a lot of them still get faxes, but instead of, so how do we then create that closed loop referral within this community, whether it is going to be to a provider, which is being done today, or to the social service, or to the transport, or the housing.
Great. We have a lot of questions that are still rolling in, so we'll keep moving along. Next question is, and I apologize in advance if any of these are repetitive in any way. Is there a billing code pathway for healthcare practitioners to use for SDoH screening?
I'll leave that to Sita. We are 100% grant funded, so we do not bill.
Yes, there are.
So I'll leave that to Sita.
Yes, absolutely. There is a whole list of Z codes, and we'll be happy to provide it to you. If you can just drop an email to Violet, that the providers can bill for the work that they do related to social determinants of health.
Great. And we did have a question in about the slides, whether they will be shared. And yes, we will be sending out a link to the recording and where you can get the slides as well. Okay, next question here is, This is a two-part question. First of all, what is the penetration rate in connecting with various EHRs that the physicians use? And out of all the patient outreaches, what is the success rate in reaching the patient?
I'll take the first one and I'll give Barb the second one. So we have been able to, HealthEC has been working, integrating with EMRs from the meaningful use one time frame when the government, when they were being funded to get electronic EMRs, and reporting on quality measures on MIPS. So we work very closely with provider communities and very closely with the EMR vendors. We have some grandfathered contracts in place where all we need to do is get a BA in place and an ID and that's the approval, and within 2 weeks we can see that EMR data start to flow into our system. So over a period of time, we've connected with 200 plus EMRs, whether it's in the hospital settings, in the ER settings, in your primary care, cardiologists, oncology, dialysis, multiple EMRs, lab data, we are able to bring into the system seamlessly. So that has been our biggest strength, I would say, whether the data comes in a flat file or it came over the HL7 CCDA formats, or it comes in, in a FHIR. Our complete stack is FHIR enabled, comes in a FHIR stack, and we've just stood up an entire system in Nebraska, getting all that data directly from the FHIR stack. So, Barb, next one is yours.
So as far as the success rate, that depends on where a referral comes from. A lot of patients who are referred to us from the hospitals, we have a very good success rate because our program is introduced at discharge. And so when they understand that that a community health worker is going to be assigned to them to help them apply for social services and apply for benefits and resources that they need, then they're open arms in receiving us and allowing us to help. So we'll probably have about an 80% rate of success in home visits, telephone calls, and follow-up. About 10 to 20% may fall, lost a follow-up, meaning they feel they got what they need and then they'll kind of fall off. So that's for our intensive care coordination program. But for our outreach programs, it's a little different. If we receive a list of patients who have a care gap, or the practice wants us to do this particular outreach, if the phone numbers are good, that determines the success rate. And also, believe it or not, the relationship that an individual has with their practice, with their provider, also determines whether or not they're going to answer the phone, pick up the phone, and then follow through on the recommendation that your primary care provider wants you to attend this diabetes self-management program, etc. So there are a lot of varying factors, but the good news is with the platform, we're able to track that by practice or by organization or by grant funder.
Great answers. Next question here is, what have you found that helps increase engagement and the cooperation of CBOs?
CBO is community-based organization.
Yeah, I'm thinking, what we do in Prince George's County is we have established what's called a community care coordination team, where we partner with, where we pull together all county agencies, hospital representatives, primary care practices, and we have invited people to engage and participate in these meetings on a monthly to quarterly basis, because it's all about relationship. And a community-based organization like mine is going to want to have a partnership with you, especially to serve your vulnerable patients. Now, there are community-based organizations that already have grant funds to provide a particular service, which would mean that your patient doesn't have to pay for the care coordination and social determinant, support and connection services. And it takes time to just investigate what's available and build those relationships. You'd be surprised if you picked up the phone and called a community-based organization and told them, I want to start screening my people for social needs, but I need help with connecting them to community resources. Please help me, you know.
So it's
And I've gotten a lot of those calls.
In one of the other states, we have a CBO of that state with about 22 FQHCs that are on our platform doing health risk screening and complex risk assessments. And the next step is to connect them to organizations like Bob's so that those they can now send the data back. So it's the way we look at this, the whole system that we need to put in place is we can come up from Barb and team or on the social side or the CBOs, but eventually they all should be integrated together. In another state, we've integrated with NowPow, which is now Unitas, and done a bi-directional. So any information that comes in their system comes right into ours, and from ours it goes to them, and we can provide the interventions to the CBOs on the platform. So it's all about integrating interoperability across our health community, across the continuity of care.
Yeah, Sita's right. I mean, there are other, and I'm sure there's some in your particular communities. There are not only there are a list of referral sources in HealthEC. There may also be lists of community-based referral practices and you know different types of community-based platforms. You know, community search. I don't know if I'm saying that right. You know.
Yeah, you're right.
Cool. Well, we've still got time for a couple more questions here, and again, please continue to ask your questions. If we're not able to get to yours, don't worry, we'll get to you via email afterwards. Next question is we conducted a similar health cost saving study after connecting Medicaid patients to community resources. However, our program started shortly before COVID. We had a hard time teasing out COVID effects to both the community resource program as well as healthcare costs. Did you all run into the same issue?
Barb, you want to?
Well, I'm trying to figure out how to answer that because and I'm also trying to remember some of the data capturing that we did around COVID, not necessarily pre and post, because COVID was such a reactionary activity that we all had to do just to get to make sure that people had the resources they needed to quarantine at home, getting food delivered to their home so they wouldn't have to come out, and test kits and all that stuff. So I don't have a good answer for that.
Okay.
I think you bring up a good point. One of the things in the data side that we have been trying to do is trying to find, you know, the COVID indicator in the claim so that we can say this set of data is COVID related and this is not. And you find some of it, but not all of it. And it's not as clean for us to truly do an analysis across that. But it's a very good question you bring up that I think we all are trying to work with on the data science side also. But overall, you know, with the numbers that the care, which is the organization that runs your numbers, Barbara? Health quality
Indicators.
Yeah, the health quality indicators, the work that Barb and team have done post-COVID at least, did show hospital charges of the patients reduced by 11,138 and hospital visits per patient reduced by 42%. We're waiting for some more reports to do some comparisons, and we'll be happy to share it if you can just drop an email to Violet on the email at the end of this.
Okay, great. So we have time for one more question, and with this one, now it would be possible to just go on and on and on and talk about it, and you'll see what I mean here in a second. But if you guys could just give a really quick, maybe 1 minute answer each to what you think, and then we'll conclude with this one. And it is, what are the top 3 most critical specific elements constituting social determinants of health that you have addressed that yield the greatest ROI?
I believe it's those who are uninsured, because once you identify people who don't have insurance and you get them insured, then that opens up all of their access to services. So we have a model where we say we're going to get somebody insured. Once we get them insurance, we're going to connect them to a primary care medical home. Once we get them connected to a primary care medical home, we're going to get them, we're going to teach them the importance of having a doctor, how to build a relationship with that doctor so that they can then, and teach them how to communicate with their doctors in their practice so that they can be advocates for their own health. And then therefore be very open and comfortable with asking questions, following the provider's care plan, and then being an advocate for their own health. So to me, it's getting insurance, connecting them to a primary care doctor, teaching them how to feel comfortable, coordinating, and as well as transportation is another big challenge. I know that's three. The transportation is also something that can be a huge barrier to someone seeking care and having access to care.
And I think what we have found as we work through different communities and the data sets that we see, we're starting to identify that it could, like I mentioned, access to care, or also the language. You know, if you don't have someone that can understand the literacy part of it, is also starting to, as like I said, as we start to pull this data, we're starting to see some trends in that direction.
And that's part of what we do, is identifying what is it that you know, what are the criteria that you want in a primary care provider. And all of this criteria and all these steps that I talked to you about are built into the HealthEC system. So when you're working with someone who needs to have a primary care medical home, we built into the system a little survey that says what's important to you. You know, and it can be, I want, you know, close to your work, close to your home, speaks your language, agrees with your practice philosophy. And then that way, that helps us to match them to a primary care office that can meet those needs, and therefore they have more capability to have a close relationship and then follow their the treatment plans.
Well, that's wonderful. Well, unfortunately, that is all the time we have for questions today. We did have more, but again, we will get back to you via email afterwards. So as we conclude, first of all, I wanted to thank again our speakers. You guys were wonderful, very engaging, and really enjoyed the presentation. I'm sure you all got a lot out of it, like we did. And as we conclude, I wanted to encourage you all to stop by the HealthEC virtual exhibit booth at vbcexhibithall.com. And here's where you can learn more about them, connect with their team. There's a lot of resources and thought leadership here. And also VBC Exhibit Hall is kind of a resource for all things value-based care. We have a reference library there with a lot of resources. It's free to use, so head over there. It's also where we're going to house the recording for today's session, so you'll be able to see that in the library and search that out there. However, I am going to send it to you guys. So when we're done here, I'm going to email everyone another hour or so once things are done processing on our end, and we'll send you the recording as well as the slides. And then finally, if you would like to contact the HealthEC or Prince George team or learn more about them, here are some QR codes that you can use. And again, these are going to be part of the slides that you can download, and you can scan them to get more information. Basically, you just hold your phone up, turn your camera on, and just look right at the thing, and then it'll bring it up. So it's kind of a neat thing. But if you would rather just send an old-fashioned email, please do that. We'd love to hear from you at SDoH webinar at healthec.com, and they will be able to connect you with Ms. Barbara or Ms. Sita or whoever you would like to speak to there, or you can reach out to me, and I'm happy to facilitate an introduction as well. So once again, thank you all so much for coming. Really appreciate your time. Thank you, Sita and Barbara. Wonderful presentation.
Thank you. My pleasure.
Have a great rest of your day. Bye-bye.
Bye-bye.